In 2015, that was basically a magic year for kind of what I would consider a renaissance in metastatic castrate-sensitive prostate cancer.
There's a lot of information to know and understand and learn with all of these different treatments, that's for sure.
I think finding methods to stay most up-to-date as you can on any of the newest literature is going to be extremely important, because we could have a study that's published tomorrow kind of redefine what is the standard of care for treatment of prostate cancer or breast cancer, et cetera, et cetera.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by Andrew Ruplin, PharmD Clinical Instructor and Oncology Clinical Pharmacist at Seattle Cancer Care Alliance and the University of Washington in Seattle, to discuss new drug approvals for metastatic castration-sensitive prostate cancer. For more information on disparities in this patient population, check out episode 149, linked in the episode notes. Astellas provided support for this podcast episode through an educational grant. Thank you for joining me today, Andrew.
Thank you for having me.
To start us off, can you just give us a brief history of treatment options for metastatic castration-sensitive prostate cancer?
Absolutely. So as the name implies, castrate-sensitive disease is treatable with therapies that modify the amount of testosterone in the body. Androgen deprivation therapy, either with pharmacologic methods such as Ruplin, goserelin, or degarelix, which suppress testosterone production via hormonal methods, or surgical methods like orchiectomy, which is removal of the testes, have been in use since the 1940s. And this was, and in a sense still is, basically the main treatment of metastatic castrate-sensitive prostate cancer. There were several new developments in the late 1980s and early 1990s when the first generation of anti-androgens, such as bicalutamide and flutamide, came into use, and since then, combined androgen blockade, use of those agents plus androgen deprivation therapy, was the new standard of care basically up until 2015. However, SWOG 9346 did demonstrate in the 2013 publication that continuous ADT was perhaps not required in all patients, and some patients could actually be treated with what we call intermittent ADT, though the non-inferiority to overall survival in those patients was less conclusive. Other than that trial, nearly all of the developments in metastatic castrate-sensitive prostate cancer have occurred since 2015, and there have been a lot of developments since then.
Thank you for that overview. We always have a new updates in pharmacology session at Congress every year, and it is astounding to me, as everyone else, how quickly we are getting new treatments for patients with cancer. So in relation to this diagnosis, what are some of the recent drug approvals that patients have?
So I kind of have a twofold answer to that question. And I think the first is that technically it depends on your definition of recent. In the past year, which I feel is what, 1 to 2 years people consider to be recent drug approvals. But in the past year, there's only been one real FDA-approved new treatment in advanced prostate cancer. And essentially, it's really just a new twist on androgen deprivation therapy, or ADT. And this is the introduction of the oral gonadotropin-releasing hormone antagonist relugolix, which again is basically just ADT, but now we can give it an oral form, whereas Ruplin, goserelin, degarelix were all given via subcutaneous or intramuscular means. My other part to that answer is that I mentioned in 2015 that was basically a magic year for kind of what I would consider a renaissance in metastatic castrate-sensitive prostate cancer. And starting then, we've had multiple clinical trials demonstrating effectiveness for intravenous chemo like docetaxel, and then other oral agents like abiraterone, enzalutamide, apalutamide, and presumably, although not yet fully published yet, the results for darolutamide will show a benefit. And that order that I listed them in is basically the order that these trials had come out in and kind of the use of these agents had been established in. It is important to note that not all of these treatments are formally listed as having an FDA approval and are instead being used off-label, despite the fact that they actually have published data showing a benefit. So among those quote-unquote novel agents, only abiraterone, enzalutamide, apalutamide, and relugolix are approved for metastatic castrate-sensitive prostate cancer at this time.
So based off of what you just said, are patients being put on clinical trials to be able to use those other therapies that you were mentioning as well?
So I wouldn't say necessarily a clinical trial is required. So the example I'll give is docetaxel. So docetaxel is not approved in castrate-sensitive prostate cancer. However, the CHARTED and STAMPEDE trials demonstrated that there was a clear benefit to using 6 cycles of intravenous docetaxel in combination with ongoing prednisone therapy, particularly in patients who had a high volume of disease. So I would certainly not say that you need to be on a clinical trial, again, for example, for docetaxel. However, recognizing that technically you may not be using it as an FDA-approved indication, but we know that these treatments convey a very definite benefit. In some of these cases, if you look at consensus guidelines, for example, docetaxel is in the NCCN, a category 1 recommendation, which is kind of their way of saying that they have basically unanimous consensus among the panel that writes those guidelines that docetaxel would be an effective first-line treatment in metastatic castrate-sensitive prostate cancer.
That is a lot of exciting new options for patients who have this diagnosis, I would say, within the last, 5-6 years. So with all of that, what do you think the new advantages are that they offer to patients?
So the first obvious answer is that in many cases they prolong life in these patients. I like to say that we get a little bit better at treating metastatic castrate-sensitive prostate cancer with each new treatment and clinical trial that comes out. But kind of the important thing to keep in mind on these trials is because 2015 is that kind of magical renaissance year, when 2015 hit, a lot of these trials were starting to be written, enrolled for, conducted. And of course, I'd mentioned that docetaxel had that trial, CHARTED or STAMPEDE. I actually can't remember which one came first, but that was published in 2015. So you had docetaxel showing benefit in 2015. Some of the other trials for like the anti-androgens were starting to be enrolled in 2015 or being conducted in 2015. So that being said, there's more variability in the disease outcomes than simply just saying that these treatments provide a benefit to overall survival. Some of these treatments were studied post-docetaxel, so in patients who had received docetaxel. Some of them allowed some prior docetaxel. Some of the trials showed a greater benefit for high-volume disease versus low-volume disease, and several other considerations as well. For example, prior to that 2015 number, the overall survival of metastatic castrate-sensitive prostate cancer when treated with just androgen deprivation therapy was only about 49 months. And by the end of the first year of treatment with androgen deprivation or treatment for metastatic castrate-sensitive prostate cancer with ADT, about 50% of men with metastatic disease will have progressed to a castrate-resistant prostate cancer on ADT. So talking about them a little bit more in depth, docetaxel, which was the first quote-unquote newer treatment for metastatic castrate-sensitive prostate cancer, showed in the CHARTED trial an improved overall survival for that combination of ADT and docetaxel, as well as continuously suppressed PSA or prostate-specific antigen levels at 6 and 12 months, which is of importance because the lower PSA values up front have been shown to be predictive of improved median overall survival. Later, we had enzalutamide, which was studied in the ENZAMET and ARCHES trials, which had progression-free survival endpoints as the primary outcome. ARCHES in particular used what the Prostate Cancer Working Group defined as radiographic progression-free survival. Overall survival was not reached in the ARCHES trial. However, even though radiographic progression-free survival has not yet been established as a true surrogate for overall survival in metastatic castrate-sensitive prostate cancer. It is an acceptable regulatory endpoint, and reducing the risk of radiographic progression or death is still of a clinical importance to us. Kind of the benefit of using radiographic progression-free survival is also that it requires shorter follow-up periods and fewer patients compared with overall survival, which allows some of these trials to be completed more quickly. Moving on a little bit further, so apalutamide and ADT in the TITAN trial improved overall survival and the radiographic PFS. And we also have the ARASENS trial, which is currently exploring darolutamide plus ADT plus docetaxel, although I still haven't seen the results published yet, but I think those should be coming out soon. Darolutamide is already approved for metastatic castrate-resistant prostate cancer, so that's something to note. And they're also planning to begin the ARA-NOTE trial, which is going to be ADT plus darolutamide without docetaxel. So to try and put all of this a little bit more succinctly, these various trials in the past 6 years have established that the combination of ADT plus docetaxel for 6 cycles, or ADT plus abiraterone and prednisone, or ADT and apalutamide, or ADT and enzalutamide are all viable considerations for the first-line treatment of metastatic castrate-sensitive prostate cancer. And I won't be surprised if darolutamide joins these ranks as well. Speaking of that newest treatment, relugolix, this offered several advantages compared to injectable testosterone suppression, and this was studied in the HERO trial. The authors stated that rapid sustained suppression of testosterone levels was superior to that with leuprolide, and there was a 54% lower risk of major adverse cardiovascular events, which was very exciting to them. Relugolix as a LHRH antagonist also helps avoid that prostate tumor flare that we sometimes have to talk about with our patients for those who are beginning androgen deprivation therapy with an LHRH agonist.
That's a lot of information. And it's a lot of amazing information for these patients that have this diagnosis. What a great long-term outcome or disease-free survival that these trials are showing and these new options for the patients. Is there a different mechanism of action than prior treatments?
So as we had kind of discussed a little bit earlier, basically for most of castrate-sensitive prostate cancer's history, treatment was testosterone suppression with ADT. So most of the new treatments that have come out have introduced kind of a new method of, or a new mechanism for treating castrate-sensitive prostate cancer. So to kind of go through that in depth, abiraterone, enzalutamide, apalutamide, and darolutamide can all fall into the larger class of what I call anti-androgen therapy, and I call it that. Many other people call it that too. It's not something I coined. But I do not to confuse these with androgen deprivation therapy. And I've heard people use ADT or androgen deprivation therapy to include anti-androgens. And personally, I fundamentally disagree with this based on the nomenclature they use in trials. So we talked about docetaxel plus ADT, apalutamide plus ADT, for example, and the implications of this mechanism of action. So to reiterate, ADT is meant to decrease the amount of circulating testosterone via inhibition of the release of luteinizing hormone and follicle-stimulating hormone by the pituitary gland, which then inhibits testosterone formation primarily from the Leydig cells in the testes. Abiraterone is what is considered a steroidal anti-androgen, but more specifically, I like to distinguish its mechanism from the other anti-androgens by calling it an androgen synthesis inhibitor, based on this mechanism of inhibiting the CYP or CYP17 enzyme, which is required for androgen biosynthesis. I do say it's a novel steroidal anti-androgen because there are some older hormonal agents which have been borrowed from other medical indications, such as medroxyprogesterone, so Provera, Depo-Provera, which can be considered steroidal anti-androgens as well, though these days I find that their routine use of those older steroidal anti-androgens in prostate cancer is quite rare. Enzalutamide, apalutamide, and darolutamide are, depending on who you ask, third generation or second generation antiandrogens, and these work via androgen receptor antagonism. The previous generations were made up of flutamide, nilutamide, and bicalutamide, but these are effectively no longer used for long-term treatment of prostate cancer. Part of the reason for this is that first and second generation, or just that first generation, if you want to split hairs, I'll be using first and second generation, have partial agonist activity and lower affinity for the androgen receptor than the third generation antiandrogens, enza, apalutamide, and darolutamide. These third generation antiandrogens also have no partial agonist activity, and they also leave less dihydrotestosterone to stimulate prostate cancer growth. So just to refresh you briefly, testosterone is converted to dihydrotestosterone via the 5-alpha reductase enzyme, which is the target for the not disease-modifying agents, but in benign prostatic hyperplasia, commonly used finasteride treatment that we sometimes hear about. Docetaxel is an old chemotherapy, I like to say, or a cytotoxic chemotherapy, but its introduction to prostate cancer was novel because it was previously thought that cytotoxic chemotherapy was ineffective in prostate cancer. Docetaxel is in the taxane class of chemotherapy, and their mechanism is that they promote the assembly of microtubules from tubulin dimers and stabilizes these microtubules in the cells, which mostly occurs in the M phase of the cell, and the result of that being inhibition of DNA, RNA, and protein synthesis and replication. Relugolix rapidly inhibits pituitary release of luteinizing hormone and follicle-stimulating hormone, and has been shown to lower testosterone levels in multiple phase 1 and 2 studies. And then, of course, we have the HERO trial as well. This has been stated to differ from traditional LHRH agonists like leuprolide, and that leuprolide and the other LHRH agonists do not fully suppress follicle-stimulating hormone, which is a potential mitogenic growth factor for prostate cancer cells.
There's a lot of information to know and understand and learn with all of these different treatments, that's for sure. As you just mentioned, all of these different mechanisms that these treatments have, and with all of the drugs having either similar or different ones, why might a patient receive one over the other?
So this is an excellent question, because all of these different treatments, there's within class differences, and some of them have several mechanisms, some of them have different mechanisms. And it's important to note that these agents have not and probably will not ever be studied really head to head. So are we going to ever see a randomized controlled trial of enzalutamide versus apalutamide? No, probably not. So a lot of the differences of why a patient might receive one versus the other are based on the side effect profile, for example. So kind of the common and classic example I like to give is we know that enzalutamide, apalutamide, and darolutamide all essentially share the same mechanism. So there's a paper that I like to direct my learners to, and this was written by one of our former genitourinary physicians, so Dr. Tia Higano. She wrote an article called Enzalutamide, Apalutamide, or Darolutamide, Are Apples or Bananas Best for Patients? And that name, apples or bananas, comes from a presentation at the 2019 ASCO Genitourinary Cancer Symposium, in which one of the leading Aramis, so that's darolutamide, trial investigators, Karim Fizazi, referred to the three third-generation antiandrogens as apples, which was enzalutamide and apalutamide, and darolutamide was a banana, to emphasize the structural differences and the similarities between them as well. So, for example, why might a patient receive one antiandrogen over the other? So darolutamide is known to cross the blood-brain barrier much less than apalutamide and enzalutamide. So sometimes you'll see this quoted risk of the antiandrogens as potentially causing a seizure, particularly apalutamide and enzalutamide if you look at the full prescribing information or other resources. Because darolutamide crosses the blood-brain barrier at a lesser rate than or concentration than apalutamide and enzalutamide, the thought is that the risk of seizure is essentially non-existent in darolutamide patients. So patients with a history of seizure were not excluded from the Aramis trial. So when Aramis is published, but Arasens, we could consider that a patient with a history of seizures could perhaps be a better candidate for darolutamide compared to apalutamide or enzalutamide. That being said, there was a phase 4 trial of men who had at least one risk factor for seizure, and they didn't necessarily report an increase in seizures compared to men who had a risk factor and were not treated with enzalutamide. So there have been some who call that seizure risk into question even as a class effect, but it is an important distinction to know that at this time, you may not want to treat a patient who has a history of known seizures with enzalutamide or apalutamide. Darolutamide is also different in that it is not quite the same CYP450 inhibitor. So the CYP450 enzymes that we commonly think about, like 3A4, 2C9, are metabolic enzymes required for metabolism of many drugs. And enzalutamide, apalutamide in particular, have a large potential for drug-drug interactions based on their ability to inhibit some of these CYP450 enzymes. Darolutamide does not have the same capacity for inhibition of those enzymes, so we might consider in a patient who has other crucial life-saving medications that could have a drug interaction with apalutamide or enzalutamide, maybe they're a little bit better candidate for darolutamide as well. I talked about side effect profile a little bit with seizure, but there's other side effects to consider. So, for example, apalutamide has a greater incidence of rash and hypothyroidism than enzalutamide. So, a patient maybe who has issues of history of skin disease or thyroid issues, maybe enzalutamide might be better than apalutamide in that scenario. So, it's all kind of a risk benefit for these drugs that have similar mechanisms of action. If you think about it more broadly, most of these agents are oral, but obviously we have docetaxel as well. Docetaxel usually given at the every 3-week interval. So in a patient, for example, who's maybe less adherent in oral medications, maybe they're better suited to getting docetaxel for 6 cycles, and they only have to come in every 3 weeks, and we essentially handle the adherence standpoint of their treatment for them. That being said, they may have to take off work or they have other engagements that they need to plan around for that docetaxel. So those are all considerations for that.
Well, you mentioned about, patients who may have a history of seizures. Are there other common adverse events that clinicians would need to be aware of with the new treatment options?
Mm-hmm. I do like to generally kind of describe them as a class effect, but when we were talking about seizure, of course, we were referring to the third generation antiandrogens, enzalutamide, apalutamide, and darolutamide. To be clear, these are not black box warnings for seizures. However, they are listed in the kind of the general warning sections of the full prescribing information. So these agents, when we're talking about seizure risk, in Enzamet, they saw 1.2% risk of seizure for enzalutamide. In Arches, they saw 0.3%. In apalutamide, they saw 0.6% in the Titan trial. And again, referring to Aramis, which is castrate resistant, but I said Arasens isn't published yet, darolutamide showed only a 0.2% risk of seizures. The other side effects I tend to think about with the antiandrogens include fatigue, back pain, hot flashes, a risk of increased cardiovascular disease, particularly hypertension, with hypertension occurring in the Enzamet trial for enzalutamide at about 20%, and in the Titan trial for apalutamide at about 17%. Also, a known increased risk of falls and fractures. So, for example, in Enzamet and Titan, they saw a respective 9.6% incidence of fall and 7.4%. I do not like to understate the importance of fatigue with my patients. A lot of patients will say, well, yeah, of course I'm fatigued. I have cancer and, I have this serious illness. But we certainly have patients who feel substantially more fatigued after starting their treatment compared to when they did before. So I like to emphasize with my patients that perhaps they should keep a fatigue journal to outline how much they're sleeping. If they find they're having increased need for naps, and you can kind of trend over time, how long am I sleeping per night? Am I sleeping per day? And we can see changes in the trends of their fatigue. Also in patients who have changes in their activities of daily living related to fatigue, I always recommend that they please call us, because certainly with metastatic disease and prostate cancer and other diseases, we want to maximize not only the quantity of life, but the quality of their life as well. Briefly, just talking about docetaxel, some of the adverse effects that I describe with patients can include neutropenia, hypersensitivity reactions, fluid retention, which we should be treating with dexamethasone pre-medication, peripheral neuropathy, though not as often as in some other diseases. We might use paclitaxel, and docetaxel usually I quote as having a lower risk for peripheral neuropathy with the use of that as well. So that's kind of the good news with that. With abiraterone, I sometimes talk about, again, because it has a little bit different mechanism than the other, changes to the adrenal pathway. So some patients have developed adrenal insufficiency on abiraterone, mineralocorticoid-induced hypertension, hypokalemia, and then elevated liver enzymes in some of those patients as well. Of course, all of these patients are getting androgen deprivation therapy or did have orchiectomy, although I find that most patients don't opt to get orchiectomy anymore when they can just get a shot every month or 3 months or longer than that even. But some of those changes that come with modulating testosterone in patients, so hot flashes, changes in energy, changes in libido, and then changes to their bone mineral density as well.
That's really good information for our listeners and to be able to be aware of what those adverse events are that we would need to be looking for with these patients. Are there any specific nursing considerations that our listeners would need to know as well when they are administering these treatments to patients?
Some of the things I discuss with the nurses in my clinic are considerations for, first of all, cost. So many of these agents, particularly the anti-androgens and abiraterone, are substantially expensive, even after insurance approves the medication for use in the patient. Some of our patients still have copays in the thousands of dollars, and we do try to help them with copay assistance programs and other things like that because they are available. But I think many individuals who are perhaps new to prostate cancer or our patients, of course, may be very surprised to learn that even though these are very well understood and tried and true treatments, that doesn't necessarily mean that they're going to be affordable by any means, which is very unfortunate from my standpoint. I do like to emphasize, particularly sometimes with nurses who are not as familiar with certain types of chemotherapy, that these I do not technically consider them traditional cytotoxic chemotherapy. So I prefer to call them either anti-neoplastic agents directly by their names in the class as anti-androgens. And some patients, I like to emphasize that with them as well, that you aren't necessarily getting a chemotherapy treatment. You're getting a treatment which is going to regulate kind of the hormonal response of prostate cancer to testosterone in your body. And this isn't the traditional chemotherapy that a lot of lay people think of when they hear chemotherapy and they think about drugs, running via IV into their arms and they feel sick and their hair falls out and all of that. Now, granted, we do use docetaxel, but for many of these patients who are treated with the anti-androgens, I like to really emphasize with them that this is not what I would consider traditional chemotherapy in that sense. I think nurses should also know that patients do need to remain on androgen deprivation therapy. So I talked about all of those treatments as being docetaxel plus ADT, abiraterone plus ADT. All of these treatments should include that ADT component as well, whether that be parenterally, subcutaneous or intramuscular, like Leuprolide or Degarelix, or now with the new oral treatment, Relugolix, and making sure that patients are still receiving androgen deprivation therapy of some kind as well. I do like to also discuss with my nurses. In my clinic, nurses do some of the education with patients, and they also do the follow-up with patients after they start their treatment. And by follow-up, I kind of mean a brief check-in with the patient to assess for side effects, concerns, questions, issues like that. I recommend to my patients and I recommend to my nurses who are educating patients that patients should absolutely let the team know of new medications started by any prescriber or new herbal supplements that patients would like to begin, again, because of the high capacity for drug-drug and drug-herbal interactions that we can see with these anti-androgen medications. So I think it's duly important that patients are aware that they really do need to tell us if another prescriber begins a new medication, because we should absolutely assess for a drug-drug interaction with that and their anti-androgen therapy as well.
Great. Those are all more good points for us to know. And talking about the patient education and some of those key points that are important for us to get across to patients. And as you mentioned earlier, a lot of these therapies are oral medications. So are there any other key educational points related to oral medications or monitoring to promote adherence that you would recommend?
I can answer this one kind of briefly because, we've talked about side effects already, and that's a major consideration for any time I'm educating a patient. But emphasizing or understanding the role of should be given with food, should be given without food, or whether it doesn't matter whether it's given with food or without food. So, for example, abiraterone should be given on an empty stomach. In patients who hypothetically consume abiraterone with a meal, they can have substantially up to potentially, I think, 10-fold higher blood level concentrations of abiraterone, putting them for substantial risk of toxicity if they're taking abiraterone too close to food. Enzalutamide, apalutamide can be taken without regards to food, and darolutamide should be taken with food. Because of the fall and fracture risks we see with these agents, particularly the anti-androgens, I do recommend patients to do whatever they can in their home or out in daily life to minimize the risk of falling and potentially having a fracture from that fall. I also like to emphasize consistency of administration with these patients. So rather than using verbiage like take once daily, take twice daily, I like to use verbiage like take this every 24 hours at the same time each day, or take this 12 hours apart as consistently as you can. I think setting those boundaries and being firm but respectful with the patient about how they should be taking these medications helps to them realize kind of the seriousness of the treatment that they're undergoing, such that we can get them the best benefit and hopefully minimize side effects and risks of them having improper adherence to their medication and potentially compromising efficacy from that standpoint.
Well, thank you. You have given us so much information today, Andrew. It has definitely been a lot of great education for our listeners. And as we wrap up today, there are 3 questions that I really like to end all of the podcast with and ask our guest. And the first one I want to ask you is, what are some common misconceptions about drug approvals?
I think particularly in the setting of castrate-sensitive prostate cancer, we kind of talked about this a little bit before, but just because a drug is approved and just because it's a newer drug that is approved doesn't necessarily mean that it's better than prior treatments, right? So when we were talking about all the different clinical trials that were used to establish efficacy for docetaxel, enzalutamide, abiraterone, darolutamide, apalutamide, again, none of these were really studied head to head. So from an FDA approval standpoint, it's going to be up to, again, the patient in discussion with their physician or their provider, what they think is going to be the best overall treatment for that patient. And I would caution, patients that just because a drug is newer, again, doesn't mean that it's necessarily better than other things that we have. Even though it's received FDA approval, it's just another treatment we have in our arsenal of treatments we have to treat their disease. The other thing about approvals is, on the flip side of that, just because a drug is not approved does not necessarily mean that it's less efficacious than other treatments. So again, I mentioned docetaxel. It's not approved in metastatic castrate-sensitive prostate cancer, but we know that to be a very effective treatment, again, based on those CHARTED and STAMPEDE trials. And we shouldn't overlook that just because it doesn't have that FDA approval.
Thank you. What is something about drug approvals that's not talked about a lot, but you wish more people knew about?
I kind of touched upon this briefly a little bit, but this is, again, an ongoing problem with any of our patients who are being treated with particularly these oral agents in particular. So just because a drug is approved by the FDA does not mean that insurance, 1, has to pay for it, or 2, is going to provide a reasonable financial coverage for that agent. So I had mentioned that Some of our patients on abiraterone and enzalutamide can have copays in the thousands of dollars per month. Obviously, that's not financially feasible for the 99% of patients that we're going to be treating. So sometimes we are even a little bit surprised when an insurance company says, no, we're not going to cover this treatment for your patient. And we're like, well, that's stupid. It's FDA approved. But that's just kind of the reality that we live in with some of these insurance companies. And what their formularies dictate is what they consider to be an appropriate initial treatment for castrate-sensitive prostate cancer.
Great, thank you. So what are some resources for patients and providers who want to learn more?
One of my favorite resources for patients that I recommend to my providers, my nurses, other pharmacists, is actually a joint effort between the Oncology Nursing Society, the Hematology Oncology Pharmacists Association, the National Community Oncology Dispensing Association, and the Association of Community Cancer Centers. And that is an online resource called oralchemoedsheets.com. And that provides vetted oral chemotherapy education handouts for patients, again, that have been rung through the ringer by nurses and pharmacists and other providers who are specializing in oncology, but also in specific diseases within oncology as well. So that's frankly one of my personal favorites for patient education handouts for oral chemotherapy. For patients in general, I think the American Cancer Society is a great resource for those patients. I think it has a lot of patient-friendly language. I think it has a lot of new developments or communicating new developments to patients with cancer so that they can understand what perhaps new directions are for their disease, what's been done in the past, how to better understand their disease, and then resource for those patients. So I always think that's a great resource for them. For providers, I always encourage primary literature to anyone who's willing to read it. Specifically, since we live in, again, kind of this renaissance of metastatic castrate-sensitive prostate cancer and in oncology as a whole, I think finding methods to stay most up to date as you can on any of the newest literature is going to be extremely important. Because we could have a study that's published tomorrow kind of redefine what is the standard of care for treatment of prostate cancer or breast cancer, et cetera, et cetera. So whatever resources providers can do to stay abreast on these new developments, whether that be through professional organizations like ONS or for me as a pharmacist, the Hematology Oncology Pharmacists Association, you can get FDA approval alerts. That's one thing you can sign up for. And the NIH, so cancer.gov, also has, of course, great resources for providers on new developments across the whole spectrum of oncology, but also in prostate cancer as well.
Okay, thank you so much. I think it's great for nurses to be able to have those resources available to them. And then to finish us off, Andrew, do you have any final comments for us today?
I think my final comments, I've talked about a renaissance in prostate cancer a lot, and I just think it's a really exciting time for both our patients and us as clinicians, nurses, pharmacists, providers, whomever you are as a provider for your patient's care team, is that this is such an exciting time with so many new developments and so much new research and resources being pumped into oncology to help our patients live better lives, longer lives, and improving our understanding of oncology as a whole. And one thing we didn't necessarily talk about was like new developments in prostate cancer moving forward. I mean, we did talk a little bit about hopefully darolutamide gets that paper published soon, but understanding new treatments in prostate cancer and how we can move those from later lines of treatment up into earlier lines of treatment. So, for example, the PARP inhibitors, which are molecular targets for BRCA mutations or homologous recombination deficiencies, are being used in castrate-resistant prostate cancer, but will we someday see them used in castrate-sensitive prostate cancer? Maybe. We don't have that data yet, but that could be an exciting new molecular target and a different mechanism that we haven't really used in prostate cancer before.
It is exciting to hear all of the new options for patients who have this diagnosis. And I just want to thank you for your time today and thank you for your expertise and being able to share with me and our listeners.
Thank you very much. It was a pleasure to be here.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.